And here's part 3 of chapter 23. Um, Speaking of genitourinary and renal emergencies, organs of the female reproductive system are separate from those in the female urinary system. In males, some of the structures are shared. Patients with genitourinary or renal conditions can experience abdominopelvic pain as well. So I want you guys to keep in consideration what are the functions of the kidneys, what are some of the signs and symptoms of a urinary tract infection, also what are some of the risk factors for kidney stones. So just keep those in the back of your mind when we go through this. That's some of the emergencies that you'll encounter when you have the genitourinary and renal emergency patients. Alright, so let's look at the what we call the genitourinary renal structures and functions. So our urinary system produces, stores, and eliminates urine. Kidneys filter the blood. They take waste products and excrete them into the urine. The kidneys also play roles in pH regulation and regulating the blood volume and pressure. So, pretty important jobs. Looking at the ureters, they carry urine from the kidneys to the urinary bladder. The urinary bladder stores urine until it's eliminated through the urethra, and in men, the urethra serves both urinary and reproductive functions. So the urinary system produces, stores, and eliminates urine from the body. In women, the urethral opening is anterior to the vagina and excretes urine. However, in men, the urethra is located at the tip of the penis and eliminates both urine and male reproductive fluid. Here's a diagram showing how the ureters extend from the kidneys to the urinary bladder. Urinary system is composed of the kidneys, ureters, urinary bladder, and urethra, and here's a good diagram of it in your book as well. The male urethra extends from the urinary bladder through the prostate gland and penis. Now for the sperm to leave the body, it passes actually through the two ducts called the vas deferens. The sperm then mixes with fluid from the prostate gland before it can be ejaculated from the body. The prostate gland surrounds the male urinary bladder and houses the first part of the male's urethra. Let's take a look at one of the conditions you can come in contact with, urinary tract infections. It's most frequently caused by bacteria that enter through the urethra. So more common in women, the elderly, diabetics, and patients who are immobile or catheterized. They also can affect the urethra, bladder, ureters, kidneys, and in men the prostate. Women, especially those who are pregnant, elderly patients, immobile patients, catheterized patients, and diabetics are actually prone to urinary tract infections. However, even though they're more prone to it, anybody can get a UTI. Some of the signs and symptoms that you'll see with a UTI going to be abdominopelvic pain or tenderness, frequently have blood in the urine. The urine may appear cloudy, have a very strong odor to it. Pain is commonly associated, usually described as burning with urination or possibly intercourse. A frequency or sense of urgency, need to urinate. They may have genital or flank pain and fever or chills. Additional signs can include nausea, vomiting, and in extreme cases, altered mental status. Kidney stones. Kidney stones are actually crystals that form in the kidneys, and they end up traveling through the urinary system. Family history and dehydration are put patients at higher risk to have them. The stones can cause severe pain. Untreated stones can lead to obstruction of kidney pathways and end up causing inadvertent kidney damage. Kidney stones are also known as renal calculi. They can be made up of calcium, uric acid, struvite, and crystine that are formed from sometimes metabolic abnormalities. The most common affected patients are going to be male from the ages of 20 to 50 years of age. Symptoms of a kidney stone, going to have abdominopelvic pain or tenderness. Most commonly it's going to be the colicky, severe back or flank pain. Groin pain, fever, and chills. The color of the urine will be abnormal. Severe pain with urination. They'll feel like they constantly need to go, or they do go frequently. Also nausea and vomiting. Older patients with kidney stones present similarly to an acute abdominal aortic aneurysm, and the latter should always be suspected. So if you're kind of on the fence whether the patient is legit with a kidney stone or not, just keep in the back of your mind there is a possibility it could be a AAA. Another genitourinary condition, kidney failure. Kidneys do not adequately filter the waste and maintain homeostasis like they should. Acute kidney injury may result from decreased blood flow to the kidneys from trauma, shock, or some type of urinary obstruction. Conditions sometimes reversible, but many patients require dialysis when they get to this point of having that severe amount of kidney damage. It can be acute or chronic. Acute kidney injury occurs over a period of several days, and as I mentioned before, it may or may not be reversible, depending on the extent of the damage. Kidney failure. Chronic renal failure occurs over years and years. Symptoms progress anywhere from mild to severe. Diabetes and hypertension are some of the leading causes. This condition is not reversible. The patient requires dialysis or a kidney transplant for survival. The renal failure, chronic renal failure, can result in accumulation of the waste products and fluids that can affect almost every organ system in the body. As mentioned before, this condition is permanent and is very, very life-threatening unless intervention is done. Complications from a patient with kidney failure include pulmonary edema, cardiac tamponade or pericarditis, inflammation of the pericardium around the heart, electrolyte and other metabolic problems, cardiac dysrhythmias, congestive heart failure, hypertension, and infections. Some of the other complications of kidney failure can also include hemorrhage, liver failure, altered mental status, seizures, and uremia. These patients sometimes present with signs and symptoms to include blood in urine or stools, altered mental status, edema of the feet, ankles, and legs, decreased or no urine output, hypertension, anorexia, tachycardia. Patients with this type of kidney failure ultimately require dialysis or a kidney plant in order to survive. And here's your treatment for kidney failure and renal disease. Hemodialysis, or the broader term dialysis. And specifically in hemodialysis, blood is actually removed from the body and circulated through a machine that filters it before returning it to the kidney. These machines actually function as an external kidney. It is something that is done usually 2 to 3 times a week. Access is through a shunt, fistula, port, or graft. A dialysis machine containing the dialysate is connected to an access site on the patient, which would be your shunt, fistula, port, or graft. The patient's blood, and they actually heparinize it. They mix it with a medication known as heparin. It's pumped through the access site and into the machine and filtered so the waste can be removed. A different type of dialysis is known as peritoneal dialysis. Fluid is placed in the abdomen by a tube, and the peritoneum functions as a dialysis membrane. Fluid is then drained from the abdomen, and the process can actually be performed at home. In the peritoneal dialysis, the dialysate is run through a tube into the patient's abdomen. The peritoneal membrane functions as that suprapermeable, semipermeable membrane during the peritoneal dialysis. And the fluid will actually remain in the abdomen for several hours so it can absorb all the waste. Then they drain it out of the body through a different tube. It's commonly performed at home, and 9 times out of 10 the patient does it while they're asleep at night. And this is just a diagram of what you may see in a dialysis patient. The access site is known as a shunt. It's a graft between the artery and a vein there, usually through the radial artery and cephalic vein. A real-time picture appears like this. It looks like some kind of structure underneath the skin. Just remember, if you have a patient that has a graft that appears this way, you don't want to do any needle sticks, and you don't want to do any kind of compression around that arm. So if you have the opportunity and the ability to take the blood pressure in the other arm, that would be prudent. You do not want to run the risk of putting pressure on one of these devices and getting a clot. And looking at the peritoneal dialysis, this is the tube that runs into the patient's abdomen to run the dialysate through. So, dialysis presents you with some very, very complex patient situations sometimes when there are complications that arise. Um, let's say that you have access to a shunt or a graft with a patient that has a dialysis appliance installed. These patients sometimes will not clot right. They may end up having an uncontrollable hemorrhage, which can result in hypertension. These patients have electrolytes sometimes that are pulled down to dangerous levels that can result in muscle cramps. These patients sometimes can have irritation of the peritoneum resulting in peritonitis. They have nausea, vomiting. The access site may not have been cleaned and they end up developing an infection at the access site. They may have an irregular pulse or cardiac arrest due to electrolyte imbalance and difficulty breathing. Although it provides the necessary treatment for patients with kidney failure, there are a lot of risks and adverse effects and life-threatening complications that go along with it. So it's not an easy road to travel. One of the biggest contributions to complications from dialysis are patient compliance. So patients say it usually goes 3 times a week. Patient didn't get their dialysis. You can have some of the most common that are just weakness and pulmonary edema and fluid buildup. In these patients, we always, of course, want to mind our ABCs. Um, Establish our patent airway, ensure it's still patent. Always make sure that they're breathing adequately and oxygenating appropriately, and look at our circulation. Give these patients oxygen as it's needed. If possible, stop the bleeding from the access site before we become hemodynamically unstable, and let's get that patient positioned the way they should and get them transported. If the patient has signs of shock, place them in the supine position. If the patient has pulmonary edema and they can't lay flat, let's place them upright. Urinary catheters are unique. They drain urine from the bladder. An indwelling Foley catheter is the most common type you'll see. Patients are prone to urinary tract infections and the device malfunctioning. That's your more common complications from these devices. They have a balloon that's inserted into the urinary bladder through the urethra. The urine drains from the bladder into the catheter and is deposited into a bag. Suprapubic catheters work a similar way, but instead of being inserted through the urethra, they are actually placed into the urinary bladder directly through the patient's abdominal wall. And here's just a diagram of how one would be inserted into a male patient. You have the device being inserted into the urethra meatus, and it goes up into the urinary bladder. Urine fills up from here and comes down the tube. You have a connection between the catheter and the drainage tubing. The bag is commonly called a leg bag. The urine will flow down here into the tube and be caught in this bag here. You usually have graduations where the urine output can be measured and calculated, and for transport I would always advise to record first how much urine is in the bag, and if at all possible empty this bag prior to transport. Just a matter of personal preference there, but if you have an empty bag, that is a less of a liability to end up with urine that is not yours in the back of the truck. Here's a patient with a indwelling catheter. That's how you commonly see them. It looks to have some type of disability with his legs there, possibly some type of fracture or previous stroke, judging by the brace, and the patient has some type of disorder to where he requires that catheter daily. And you notice the leg bag on the walker with the tube that goes up the pants. So managing a patient that has a catheter, we want to make sure that we note any unusual color, bleeding, swelling, or odor. If possible, as I mentioned before, drain the bag before transport. Record the amount drained and the time. Make sure there's no kinks in the device and that it's free from anything that you get caught on before you move the patient. After you transfer the patient to either the cot or the bed, ensure that you lower the bag so that the urine can flow freely into it. And let's take our assessment-based approach towards the genitourinary renal emergency. Of course, as always, we're going to ensure that our scene is safe, take all of our standard precautions, figure out whether a patient has been injured or is suffering from a medical illness. And let's move to our primary assessment. Let's form the general impression from the following. What's their mental status? What does their airway look like? Are they breathing adequately? Are they oxygenating like they should? And are they showing signs of adequate circulation and adequate perfusion? Because these patients can have many complications, the patient may be disoriented or unresponsive. Ensure that that patient has an open and clear airway and use mechanical airway device if necessary. These patients are high priority transports if they exhibit any of the following symptoms. If they have a poor general appearance, if they're unresponsive, responsive, not following commands, exhibit severe pain or signs of shock. So moving on to our secondary assessment, we want to always protect privacy and modesty. Be compassionate and professional. Get a good history and perform a physical exam and get some vital signs. Ask questions involving personal issues that some patients can be hesitant or embarrassed to answer. Be patient and compassionate and professional when you communicate with these patients, because talking about these body systems due to what structures, what anatomical structures are involved can be very embarrassing sometimes. All right, when you're asking your history, just look at our signs and symptoms. What, when, how fast, what was the patient doing at the time, any allergies, what was the patient's last oral intake, do they take any medications currently, what's their past medical history. If applicable to the situation, ask when was the patient's last menstrual period. Is there any genital pain or discharge? Is there a change in urine? Does the patient receive dialysis? Do they have any abdominopelvic or flank pain? Also ask if the patient has any pain associated with urination, defecation, or sexual intercourse. If the patient receives dialysis, when was their last treatment received? Was there any complication during dialysis, and when is their next treatment due? Has there been any nausea, vomiting associated with this condition? Um, some additional signs and symptoms: is the urine been abnormal color, consistency, or does it have a strange odor to it? Um, the nausea, vomiting, abdominopelvic pain, and tenderness. Try to ascertain if the patient's had any fever or chills, syncope, altered mental status, any pain or burning during sexual intercourse, flank, groin, or back pain, frequent or urgent need to urinate, or any blood in the urine. Looking at additional signs and symptoms, look at their feet. Do they have any edema in the feet, ankles, or legs? Do they exhibit any hypertension? Have they had any loss of appetite known as anorexia? Are they tachycardic? Are they showing any signs of shock? Let's go to our focused physical exam. The physical exam is primarily going to focus on the genitourinary or renal complaint, and is normally going to involve the abdominopelvic area. Um, Genitourinary renal conditions can affect other body systems. Therefore, you must assess anything related, such as cardiovascular and respiratory, for any signs and symptoms. But primarily and initially, let's assess the abdomen, and then we're going to assess our other systems after that. If there is a catheter, let's observe the amount and appearance of the urine. Um, Take a good look at it, because that's going to be a really good indicator in these patients that have catheters in place. And also take and record another set of vital signs. And our treatment and care for these patients, if it's needed and applicable, any signs of trauma or suspected trauma, let's establish spinal motion restriction, maintain our airway and ventilation, maintain our oxygenation, any major bleeding noted, we need to get that control, and also position the patient according to the condition that they're in. Sometimes these patients can appear anxious. We want to calm and reassure the patient and transport them. Then we're going to go on to our reassessment. We want to continuously monitor the patient for changes in their mental status, airway, breathing, and circulation. Sometimes these patients can be considered critical. We want to reevaluate them every 5 minutes. So in summary, gynecologic conditions can present with abdominopelvic pain and vaginal discharge or bleeding. We want to be aware of special considerations of managing sexual assault patients, protect the patient's privacy and modesty. There's many potential causes of abdominopelvic pain, many which can be very serious. In emergency care, we want to anticipate vomiting and be prepared to manage that airway. Be very aggressive when managing the airway of patients with abdominopelvic pain. Make sure the patient is as comfortable as possible and be alert to the possibility of shock. Hematologic conditions are problems with the blood and blood components. Problems EMTs may encounter include anemia, sickle cell disease, and hemophilia. Genitourinary disorders can present with abdominal pelvic pain as well. Urinary tract infections and kidney stones are very common problems. A large patient population presents with those symptoms. Patients with chronic renal failure require dialysis, which can have serious complications. This should conclude chapter 23, and good luck to you.